Well, hello, everyone. It's 1:30, and so we've got a lot to cover today, so I'm going to go ahead and get started. I want to welcome everybody to day 3 of Work to Include's Employment First Summit. My name is Susan Rennie, and I'm co-director of Work to Include. And for those of you who are new to Work to Include, we are a statewide disability-led initiative working to improve the employment outcomes of people with disabilities both in local communities and statewide. We're about looking at systems and making systems work better. We're about informing people about the services and supports that are available to them and making sure employers across our state understand that there's a talent pool that's waiting out there that have the skills and are interested in the jobs that are available. So for those of you new to Work to Include, I would really highly recommend you go to our website, worktoinclude.org, very easy to remember, and check out all of the things that we've been doing over the last couple years. So I am a white female, medium brown hair, and blue eyes, and maybe one gray hair for every one of the 40 years that I've been in this business. So I've been in disability services since 1978. So seen lots of changes, lots of improvements, but also get a little frustrated with the things that we have to work to do. One of the reasons we're holding these summits is to help us think about those changes and to come up with some ideas for how to keep moving things forward in the state. So welcome. I want to first thank all of our sponsors and hosts. The Indiana Governor's Council for People with Disabilities has provided funding for this summit and for Work to Include since 2019. And I want to thank them for all of their leadership where it comes to employment first in the state. Christine Dahlberg is an amazing woman who's really made employment first a focus of the Governor's Council. So thank you. Indiana APSE actually provides us with a lot of support. Their social media person, Case Calvert, is the person who designed our wonderful website and has worked on our social media campaigns and helped us to improve our social presence. We have a Facebook page, and we have 500 people that have liked or followed our page. So please see, we try to keep everyone up to date on policy initiatives in the state and nationally. And then Pat Rogan, who's on faculty at IUPUI, is the other co-director of this initiative. She's done an amazing job the last several days getting this summit going with her moderation, and I can only hope that I can do somewhat close to the job that she's done for the last couple of days. Thanks, Pat, for getting us moving. So I just wanted to go over the agenda and some logistics. I know this is a full day, so we've got lots and lots of information. So I wanted to kind of give you an idea how that was going to lay out and get your help with making sure that we get your questions and we get moving through the agenda smoothly. So what we plan to do today is spend some time first thing learning about Medicaid buy-in in Indiana and MedWorks. And we have a couple people from OMPP I'll introduce in a moment who are going to be walking us through that. And then we're going to learn how Medicaid buy-in can work differently, how it looks in other parts of our country, and maybe get some ideas for things we can do both regulatory and legislatively to make a difference. After that, we're going to hear from someone from the state of Oregon who has worked to develop a system of services and supports that's moving people from sheltered work into community employment in Oregon. And she'll talk about those special circumstances that they've been under for the past several years and how they've really shifted their service delivery system and used waiver to do that and created service definitions that include benefit counseling. And then we're going to get together in small groups and discuss what we heard and come up with things that we think will make a difference in the state of Indiana from the things that we heard. There is a, excuse me, let me go back. Ah, I love when technology works or doesn't. All right, there's a brief survey that we're going to ask you to fill out at the end, and it actually outlines some of the recommendations from the Indiana Employment First Plan and allows you to make some recommendations about how in the world we can move things forward. And I just wanted to share that briefly with you. This is the set of recommendations from the plan that relate to this area. They include expanding transportation options and some activities under that, promoting the value and benefits of employment and the rights of people with disabilities in the workplace, and increasing the use of work incentives and benefits planning counseling. So what we're going to learn today, we want to figure out how to augment the things that are already being planned by our state. So look for that link that will be in your chat box, and that link will take you to that document so you can reference it, you can download it, print it out if you'd like. And then the final thing that we'll do is to come back, wrap up, and we'll show you some of the other things that came out of the breakout sessions from day 1 and 2. So again, just a few logistics. Everyone is going to be muted during the sessions. So we're asked that you, if you have questions, if you have comments, we want them, and we actually will be able to print them out and make them available at a future time. So please do put your questions and your comments in the chat box. We'll track those. There'll be a brief Q&A at the end of each session, but unfortunately, we're probably not going to get to all the questions people would have, I would imagine. So if there aren't questions that we don't get to, we've asked our speakers if they would be willing to respond to them, and we will include the results of that in our newsletter. And if you're not currently on our newsletter list, again, very easy thing to do. Just go to worktooinclude.org, scroll until you see sign up for the mail for the newsletter, put your email in, and you'll automatically be enrolled in that. So the breakout sessions, I'll talk a little bit more about when we get there, but I just want you to know that those are going to be random assignments, and we do have facilitators who volunteered to help with that. Those are all Work to Include team members, team leaders, or advisory committee members. So all volunteers. We'll go over the materials and the process for that ahead of time, and we really would like for you to stay with us because that's going to help us come up with those other ideas that maybe are not yet included in the plan that we have for the state. And we also just wanted to make sure that you know that all the handouts, all the recordings, and all the polls that we take are going to be on our website after the event. So don't worry about taking copious notes. Put your pen down, listen, give us your comments and your questions. So what I'd like to do next is to turn this over to our first set of speakers. Bree Antigue is the Section Director of Government Affairs in the Office of Medicaid Policy and Planning. Breanne has worked with FSSA since January of 2019, and she has a history of work in government administration, specializing in policy and compliance. Brian Gilbert is the Program Administration Manager, And he is also on the advisory committee for Work to Include and has been a really big help to us in understanding how Medicaid and work fit together. And he's also on the board of Indiana APSE, our major partner, as I said earlier. So with that, I'll turn it over to Brian. Are you going first?
I'm going to share my screen. Brianne will start us off, but I'll bring up the presentation.
Okay. All right. Thanks, Brianne. Thanks, Brian.
Thank you, Susan. Well, I want to thank everybody for listening to our little presentation on MedWorks and what it involves. So if you have questions, and we've got a little bit of time, don't hesitate to ask them. And as Susan indicated, that some of the presenters, including Brian and myself, we are available for questions via email too, should we run out of time. So I just want to thank you all for sticking around and listening. And so MedWorks, this is a really brief look at what the buy-in program is for MedWorks. It was effective in July of 2002, and it stands for Medicaid for Employees with Disabilities. It falls under the umbrella of Hoosier Care Connect, but it does include quite a few fee-for-service waiver members. It's about 2,500 fee-for-service members compared to 653 Hoosier Care Connect members. This program allows individuals to work without losing their Medicaid coverage. MedWorks includes a lot of flexible features, one of them being you're allowed to have a higher income threshold for eligibility and coverage maintenance. You get the same coverage as regular Medicaid. You're able to save money for retirement, as well as certain work and educational goals. You pay on a sliding scale premium that's based on your monthly income. You can maintain your coverage for 12 months following involuntary termination of employment. You can save up to $20,000, but you have to explain what that money would be used for. Some of the necessity, like if it's necessary for your employment, part of your application for saving the money would include your expected purchase date of the item that you may need to maintain your employment, for example. And you can achieve this in a reasonable amount. If you could achieve it in a reasonable amount of time. I apologize. So those are just some basic features of it.
And so I'll jump in now and we'll talk a little bit about the eligibility piece for MedWorks. So first thing is you have to be Medicaid eligible in general. You have to be between the age of 16 and 64, and you have to meet the Medicaid definition of having a disability. And you also have to be working. So this is something you have to notify DFR when you start working so that they know to switch you into MedWorks, or if it's your initial application for Medicaid, you need to let them know that you're working to make sure that you get put into that correct category of Medicaid. And then for eligibility only, the income is between 100 and 350% of the federal poverty level. A few things that are not included when determining eligibility for MedWorks. As far as income, they will not look at any tax refunds, any grants or scholarships allowable by federal law. We might talk about this later when we get into the benefits planning, but any impairment-related work expenses are deducted when looking at income. And then for eligibility, income of spouse or parents, if you're living with parents, that's not included either when looking at eligibility. Assets, because you do have to meet that $2,000 asset limit for individuals. They do not take into account if you own a car, if you own your own home, burial spaces, and any retirement savings that are held by you or a spouse if you're married. So this is just a quick look at the 2021 federal poverty level chart. So you can see when we talk about that maximum of 350% FPL for a single individual, that comes out to about $44,000 a year. For a married couple, it's about $59,000 a year. And then here we have a quick look at what those sliding scale premiums look like for MedWorks. So if you're earning between 100 and 150% of FPL, there is no monthly premium on MedWorks. And then you can see as your salary increases, as your countable income increases, that the monthly premiums also go up, and they have separate calculations for single individuals and married individuals. So here, if you're married, they will be looking at your income as well as the spouse's income. It's only for that eligibility piece that they do not look at spouse's income. And then this slide just gives a really quick overview of who's using this program. So like Brianne said, there's about 3,100 individuals who are currently enrolled in MedWorks, and a vast majority of them, it's about 79%, are in fee-for-service. So those are individuals who are on one of the HCBS waiver programs and receiving MedWorks. And then this chart shows the breakdown percentage by the premium that's being paid. And in looking at the premiums, what you're seeing is really 75% of individuals who are on MedWorks are single individuals earning between 150% to 250% of federal poverty level. So again, if you go back to the chart that breaks down those different levels, that's around $19,000 to $32,000 per year, where a vast majority of individuals are falling into. Wanted to take just a minute to highlight a couple of the other things that Medicaid has been involved with regards to employment. Currently, we're working with the Division of Disabilities and Rehabilitative Services as they're planning kind of a waiver restructuring. It was originally meant to be a waiver redesign. COVID kind of threw a wrench in those plans, but in looking at restructuring the waivers, we really are taking a long, hard look at the employment services and how we might be able to improve those to achieve better outcomes for members of the waiver. And then we've also begun to work with vocational rehabilitation and the Division of Mental Health and Addiction. They're working on called the Aspire project, where they're going to be selecting 3 or 4 early adopter sites, and they're trying to really move forward evidence-based practices and support employment for individuals with a mental illness. And Medicaid's role in that is looking at ways to kind of get a braided funding model going, where Medicaid rehabilitation option might be able to be used to kind of supplement a lot of the VR activities. So I know that was a really quick overview, but we wanted to leave a few minutes for questions at the end in case there were any. So any questions?
Again, you can put questions in the chat box. Here's a question. What happens after age 65, Brian?
After age 65, you're no longer eligible for MedWorks. So if you still you'd still be able to be shifted to regular Medicaid, but that would depend. If you're earning above that threshold, then you would not qualify. You might be switched over to Medicare though at that point.
Mm-hmm.
Thanks, Carolyn. And Derek Nord asks, is there an income requirement or is there an income maximum? I know there's an income requirement.
So once you're working, there is no income maximum. The income limit is to get onto MedWorks initially for that eligibility piece. Once you're working, there's no limit. You just hit that. If you hit that 350%, it's sort of the maximum level of premium that you would pay.
So that means if you earn above 350,000 after a number of years, you'd still be able to purchase Medicaid.
Correct. You would just have that premium to pay.
That's fabulous. And then the next question is, how do ABLE accounts work with MedWorks? That's from Christine.
So the ABLE accounts, that would probably be a question for benefits folks. I don't think that's tied to MedWorks. Those are just separate savings accounts in general.
Great, great. If someone's on from one of those beneficiary or benefits information networks, if you want to put the answer in the chat, that would be lovely. Lindsay asked, is child support counted as income for Medicaid or MedWorks?
I would have to double check that.
Mm-hmm.
I believe it is counted, but I don't want to say for sure, but I can definitely look into that. And if you wanted Susie to include that with the questions that we don't get to as well.
That's great. Can do. I knew there were going to be lots of questions, guys. Here they're coming. Anne asks, any idea when the state will start asking people to pay premiums again?
So that's something that we're currently waiting for direction from the governor's office. It's tied to the public health emergency, and as those executive orders roll back, then we'll start looking at making those changes to Medicaid. We don't have an answer right now, but that's something I know the governor's office and FSSA are in conversations about.
Great. So that would be something we could share via our newsletter. It would be lovely to be able to let people know what's happening there.
Absolutely. There should be plenty of notice when things start to change. We're hoping for public notice, and we're hoping for a lot of those bulletins and banners that go up. And DARS has a newsletter, I believe, and we think that that's going to be, we're going to have hopefully ample time for people to prepare, but I can't give a direct answer on that just yet.
So Tina wanted us to clarify what is the most you can make and still retain eligibility?
There is no limit.
Gotcha.
So
That's
I guess
lovely.
infinity.
Then Christina asked, not sure if this is appropriate, why MedWorks instead of employer-provided health plan? Oh, that's a great question, Christina.
Can you repeat that question again?
So she wants to know is why do you need MedWorks if you have employer-provided health plan?
Sure. I think, one of the best general examples when you look at the number of individuals who are on the waiver, a lot of the services these individuals receive are services that are not available through private health insurance or through employer-sponsored health insurance. And these are a lot of those attendant care services, the assistance services that are really allowing them to have that support to work in the community. So without the Medicaid piece, you're looking at potentially having to pay for that out of pocket, which would eat into a significant majority probably of someone's salary.
Gotcha. Yes, and that's what we've heard a lot from people is that, there are services they need that aren't going to be paid for under employer-based health insurance. And then I'll just give you this one last one. Annette asks, where is the information located for beneficiaries and interested people on the lack of income limit? Where can they find that information about eligibility, Brian?
I can get that link and put that in with the other answers. It's on the site, but I don't know the link off the top of my head, but I can definitely get that and we can add that to the newsletter.
Well, and I had one more. Sorry, I told you that was all, but if we can get to them all, wouldn't that be great? Kelsey asks that they struggle with the local FSSA office to recognize MedWorks and switching people over. Is there a way to help facilitate that?
So is that when they say FSSA, are they talking about when they go to their DFR office?
I believe so.
You know,
So they've had trouble with people who have information, I would assume, about MedWorks.
You know, I'm more than happy if someone is having a struggle with DFR, with getting set up with MedWorks. My contact information is here. Someone could reach out to me and I could get them in touch with the right folks over with the Medicaid eligibility who could help them resolve that.
Great. And Carolyn, yes, I'll just make sure, because I think we did answer this when she wanted to make sure this got asked, that she's on Medicare, Medicaid, and Social Security disability, and she's 64, wants to make sure she doesn't lose everything when she turns 65.
So MedWorks, if she was on MedWorks, that would not continue.
But Medicare, Medicaid continue.
Mm-hmm. Medicaid, right. It would kind of go back to the traditional Medicaid eligibility requirements.
Mm-hmm.
Great. And there is a link in the chat box from Jennifer Akers. Well, thank you guys. Very, very good questions. A lot of great information. And we really appreciate you being here today. We'd love for you to stick around and listen to our next couple of speakers, because they're going to focus a lot on Medicaid buy-in and what's happening in other parts of the country. So I'm real interested to see, how what we're doing is different or the same. So I want to just shift gears here for a second and introduce our two speakers in this next section, Annette Shea and Beth Waldman, sorry. So Annette, in the upper left there, she worked in the health and human services field for over 25 years. She has an emphasis on Medicaid and developing systems that support employment and community living for workers with disabilities. Annette worked for the U.S. Department of Health and Human Services at the Administration for Community Living and the Centers for Medicare and Medicaid Services. While at ACL and CMS, Annette was the subject matter expert for Medicaid buy-in for workers with disabilities. Prior to working with ACL and CMS, Annette worked at the Massachusetts Medicaid program as the Director of Disability Policy and Home and Community-Based Services. Waiver oversight with responsibilities including Medicaid buy-in for workers with disabilities. She currently works as an independent consultant. So I'm going to turn it over to Annette, and I'll introduce Beth. Annette, when you're done.
Great, thank you, everyone. It's really great to be here. I appreciate you including me in this. I want to make sure that, Susie, can you let me know that this screen is being shared? Can you see it?
It is.
All right. Okay. So as I said, I'm really excited to be here and grateful that you've given me the opportunity to help Indiana as you contemplate making your MedWorks of a stronger work incentive option for Indiana residents with disabilities. This slide talks about the authorities that states use to implement Medicaid buy-in for workers with disabilities. And that is the BBA and the Ticket to Work option. Both require that beneficiaries with disabilities meet the Social Security definition of disability. SSA enrollment is not required, and for people applying who haven't gone through a Social Security eligibility pathway, the state conducts its disability determination using the same criteria. Okay. Medicaid buy-in for workers with disabilities offers states the option to and the potential so that people no longer need to choose between healthcare and work. Most states have their own brand, like Indiana having MedWorks, and that is maybe to give it its own, work promoting type moniker. Also, keep in mind that the nickname Medicaid buy-in now applies to more groups than Medicaid for workers with disabilities. So you may hear people specifying that more frequently. And it's important to note that Medicaid buy-in for workers with disability members are more likely to utilize Medicaid as a supplement payer source and not because they have access to Medicare or employer-sponsored insurance. And why do we need Medicaid buy-in for workers with disabilities? And this applies to the questions about, well, what if someone has employer-sponsored insurance, why do they need Medicaid buy-in? If someone has Medicare, why do they need Medicaid buy-in? Well, because Medicaid offers services that no other payer source does. And these folks who need access to services like personal care attendant services, home and community-based services, durable medical equipment, extended therapies, they're not going to get that anywhere else. So that's why, yes, you can have private insurance and use Medicaid as a supplement to get the services that you need to maintain or achieve successful community living. This slide, it talks about the investments that Ticket to Work made, the Medicaid infrastructure grants, which some of you may be familiar with. They spanned an 11-year period, and this is where Medicaid buy-in really took off. More states adopted the option, and more states built up their infrastructure, whether it's through training or outreach or systems change, analysis on current, their current beneficiaries, and how there's the vast majority of people who go to Medicaid buy-in likely came from another traditional Medicaid group. It's earnings that put them in to their Medicaid buy-in program. So that over that 11-year period, they were allowed to conduct in-state analysis and also rely on the national evaluation of the Medicaid buy-in program by Mathematica. And so that's where I wanted to note, and also the former presenters noted that July 1st, 2002 was when Indiana implemented its Medicaid buy-in program utilizing the Ticket to Work Authority. So one of the things that may not be known to folks is that the research and data analysis helped us better understand the importance of Medicaid buy-in and its role in the broader continuum of access to healthcare. We have analysis, particularly when there was more resources dedicated to it back during the MIG years, that show that as people's income go up, their expenditures go down. There's also research that shows the value of employment, particularly for people, as with they noted that the state is engaged in the Aspire grant. People in recovery from substance use disorders or behavioral health disorders, they can consider employment part of recovery. One of the values of the investment that MIG made was to help make the business case for Medicaid buy-in as something that really supports, strategically supports states in promoting employment, also helps with the state's expenditure bottom line and helping them achieve cost savings and sustainability. How states, this is a technical piece, how states achieve the option of being more generous in terms of the income limits or lacking an income limit is the use of something called a 1902 R2, disregard of the Social Security Act. That is not something known to many people, but that's how states are able to achieve their employment goals. And it's a critical resource in promoting employment. And how states make changes. What's happened is, as you saw the year that Indiana implemented their buy-in, they then, like other states, may take time to say, okay, is this really what we wanted it to be when we implemented this many years ago? What does the population look like? What do we want it to look like? How are we ensuring that it's truly employment and earnings friendly? And you make changes with the using a state plan amendment to Medicaid. And this slide is a reflection of Medicaid buy-in across the country. This 45 states is likely 46. I had trouble finding New Mexico's information, and I'm still working on that, but I do believe they'd have a buy-in. I just don't have information on it. 8 states have no earned income limit, and if Indiana truly has, as I believe you, I'm thrilled that you don't have an income limit. It's not known. That's why I asked about where the information is and whether that's something that maybe could be promoted more. But it is considered a bipartisan approach to access to healthcare. So this is not a big E expansion in sort of the truest sense of the word. So the other states that I'm referring to here without an earned income limit are Wyoming, Alaska, North Carolina, Minnesota, Massachusetts, Michigan, Arkansas, and Washington. And Oregon currently has legislation pending where they're aiming to remove income and asset limits. And I think we have someone from Oregon on after we speak. There's also the trends include, as I note here, being more allowing individuals to accrue some assets and also not counting spousal income, determining eligibility or premium calculation, having a grace period, adding the 65 and older group. There are currently 14 states that include the 65 and older group. And there are more states on the horizon that want to do that because they're now realizing that first, that it is something you can do. I think there was maybe some misconception or misperception that it's not available to Ticket to Work states, but it is, but using the BBA authority. And so now once states learn that and they realize that, like the previous questioner asked, what happens when someone turns 65? They don't want them to have to then impoverish themselves to access the services they need. So I'm just going to quickly go through some of the features that promote employment and earnings, and that's, as I mentioned, the financial eligibility methodology has no income limit or a higher income limit. As was previously stated, Indiana has countable income at 350% federal poverty level, and that amount, as was mentioned by the previous speakers, is about $3,700 monthly and $44,000 annually. The asset limit, the earnings promoting policies would be no asset limit or the inclusion of earnings as non-countable resources like independence account. So Indiana has those asset limits of $2,000 and $3,000, and that's the really Social Security limits and traditional Medicaid. They do have, you do have this Medicaid account for people to use for independence and self-sufficient self-sufficiency, and there are some, of course, rules that apply to that, and I've noted them here. They're familiar, I'm sure. And also that to make sure that you're being thoughtful about how income is being counted, financial eligibility that doesn't include a spousal income, so that the spouse not being a beneficiary is not facing a barrier to employment, so that the spouse may access the services they need. In Indiana, it does not include spousal income in calculating their eligibility. So, and if no premiums, or if premiums are used, the methodology factors impacts employment. It does not impact spousal income. And as noted, Indiana does include spousal income in the premium calculation. I will note, if you're asking for, it may not be clear. If you're asking an applicant to include spousal income, there may be confusion about why, if you're not including it. And then that could present also a barrier to income and employment for the spouse or for the family, if you think about them as a couple. The grace period as a programmatic feature, that's when because we know that these folks, they transition in and out of your MedWorks. They may have an interruption in employment for no fault of their own. They may have a medical reason, and they have to shift back into traditional Medicaid to get the services they need. You don't want them to give up on employment. So you want to make sure they stay connected, even just to the idea that they're going back to work. The inclusion of workers with disabilities 16 to 18, that is youth in transition, and 65 and older. Indiana, using the Ticket to Work authority, includes workers 16 through 64, as we talked about, and as mentioned by the previous speakers. I included some resources. I have others that I just didn't want to inundate you with a lot of links at this, for the purposes of this presentation. The R2 disregard Olmstead letter you may find interesting, and then there's a basic Q&A that is on Medicaid's website that was written by yours truly. So of course I'm going to promote it. And then we'll just leave open some discussion. And my contact information is at the end. But I think, Susan, you wanted to have some time for questions.
Yes, thanks, Annette. Yes. And again, I'm sure there are several questions for you. So if you guys want to start putting things in the chat, we've got a few minutes for that. See what we get.
Okay.
So we did have a comment from Carolyn that it would be great to add 65 and older group, especially since there has been conversation about increasing the age when someone's eligible for Medicare. So,
right, that's true.
So
other states with the same thing. If you're not eligible until you're 67, but then you lose your health care before even you have Medicare to offer even some of those basic services, then that is definitely problematic. Other states are looking at that too.
Yeah, definitely need to make sure we fill that gap. So, oh, sorry, go ahead.
I was just going to say, I said, even recently I had a Medicaid director say to me, I don't want to be forced to give up work. I'm getting up there in age, and it's just kind of the whole perception of allowing people the option of remaining or achieving their employment goals regardless of age.
So Anne asks about what you're supposed to do with unlimited income, since there is an asset limit. So you're going to have to spend money. Christine suggested cars and houses and retirement. So I don't know if you have any other suggestions.
If I would say that that's a good question for the state, whether or not that they may not have, that may have been an unintended consequence, that if folks have the opportunity to achieve increased earnings, but yet they bump up against an asset limit, maybe that provides for conversation for examining that.
Oh, that's great. Carolyn asks, so will VR not be able to assist people with disabilities over 64 that want to find employment?
I don't have the answer to that. Well, I don't know what VR is allowed to do, but it would mean that they would have to be an informed decision about employment and access to Medicaid.
And then Mitch asks, do assets include stocks?
The state folks noted that something about retirement funds on the list of non-countable. So I don't know if that means if you're referring to a retirement account with stocks, but countable. It sounds like it may be countable.
It sounds like it may be countable. I was going to ask you, of the states that you've worked with, who would you say, has, I don't know if it's the best, but, has a Medicaid buy-in program that has all of the elements that maybe we could look at as an example?
I would say that right now, the Washington State implemented, they had no asset limit. They just added the 65 and older population on January 1st, 2020, and they removed the income limit. Yeah, that would be Washington State. I mean, there are a number of them. The states with no income limit, there are some with no earned income limit, but they have other unearned income requirements. So states like Alaska and Wyoming may have that. North Carolina may also be an interesting state to look at. When they removed their income limit, they added the premium structure, but they also added like an enrollment cost, like an application cost as part of cost sharing. But there are any of the states that are more generous when it comes to no income limit. I have a lot of experience with Massachusetts, so of course I would say they would be worth a look, but they do count spousal income for their premiums, and that is something that they looked at years ago to change, because I do think they understood the unintended consequences. So I don't know whether they have plans to make any changes, or whether maybe they have more recently and I'm just not aware of it. But yeah, I know that's a secret. No.
Another question has to do with Ticket to Work, and if there's any talk of expanding that program, that it could be better in terms of lending assistance and job seeking for people with disabilities.
If you're talking about something outside of Medicaid, I don't know anything, whether or not they're changing the ticket itself. But I do believe that there is talk at the federal level. There are members of Congress who, and advocacy groups that are working with them, asking them to remove the age limit from the Ticket to Work authority. And there's interest. There's a lot of interest in doing that.
And I do want to mention that Emily Munson from Indiana Disability Rights weighed in on the VR question that they can't discriminate against people who are over the age of 64. So they have to provide those services. And then finally, I have a question about ABLE accounts. and whether additional income could be placed into ABLE accounts. Do you have any information about that?
Up to the cap, up to the annual cap. Yes. Which it goes up every year. I don't know an exact amount, and it should not be countable for the purposes of Medicaid eligibility. There is a state, people are interested. There's a state Medicaid director's letter that went out maybe 3 or 4 years ago, which provided information about the role of ABLE accounts for the purposes of Medicaid eligibility.
Gotcha. Well, those are all the questions that I have here right now, Annette. If we get more, I will send them your way.
Great.
And I really appreciate your conversation and your willingness to kind of help us look at what might be some things that we may need to focus on in Indiana.
Great.
So thanks a lot.
Thank you.
We're going to shift gears, and I'll remember to share my screen. I've got some really great helpers in the chat box, so thank you guys. Is technology sometimes. I've just been amazed the last couple days how Pat's been able to go back and forth with these. So working on it. So next up, we have Beth Waldman, and get to see Annette's wonderful picture that you didn't get to see before. And here's Beth. Beth is a senior consultant with Baylet Health and a national expert in healthcare policy. The Baylet Health firm has that expertise, and it works on program development and implementation, specializing in Medicaid and the CHIP programs, and also looking at coverage for the uninsured. During her 14 years with Baylet, Beth has been actively involved in efforts across the country to improve access and delivery of healthcare to low-income individuals, while working to make coverage more affordable and assist payers in efforts to expand value-based purchasing. Beth's work includes assisting states and other stakeholders in delivery system and payment reform design, including of several different mechanisms and development of Medicaid buy-in programs, which is our discussion today. So Beth served as Massachusetts Medicaid director and was responsible for the administration of all of Massachusetts Medicaid programs in the past, prior to going to Baylet. So I will turn it over to Beth. Thank you very much.
Oh, thank you. I am going to try to share my screen. Let's see. Are you all seeing the slides now?
Yes.
Okay, great. Thanks for having me today. I'm happy to be able to talk about the Massachusetts buy-in program. It's a little funny to go after Annette because she really is probably more the expert on the Massachusetts buy-in program than I am. So I'm glad to see she's staying around in case people have questions.
Beth, do you want to put this in presentation?
Oh, sorry about that.
That's
Sure.
Okay. That's okay. Believe me, I know how not hitting the right button happens.
Let me see how I get to presentation mode.
If you go down there.
Slideshow from beginning.
Yeah, I just can't see the screen because of where my, where the Zoom is. So that's what the problem is. Sorry about that. Yeah.
Can you see the bottom of your screen, Beth? Bottom of the screen, sometimes there's a little, what looks like a screen. If you just, that little button down there, that'll do it. Oh, well, that just gave you a different view. It's the one just to the right of it.
No, all the way left.
Left of it.
Or right.
There we go.
There we go.
That? Okay, sorry for my technical difficulties. I'm going to talk about the Massachusetts program. It is different than any other program. Of course, we can't do anything easy, but that's just the way we've been in Massachusetts. So let's get going. So Massachusetts is the first buy-in program in the country. It came out of legislation in 1988, actually. That was one of Massachusetts's first try at universal health care coverage, and really the only thing that ever got implemented out of that legislation was the Common Health program, which would allow individuals with disabilities to buy into the Massachusetts Medicaid program. So it precedes BBA, it precedes Ticket to Work, and originally was implemented as a state-funded program so therefore only Massachusetts dollars. And was moved into our 1115 waiver program when we implemented that in 1997. The program is called Common Health, and in Massachusetts, it goes beyond working disabled adults, but includes anybody who is disabled. So disabled children with family incomes that are above the eligibility criteria, disabled adults that are over income, and then working persons with disabilities. And today I'm just going to focus on the rules relative to those working people with disabilities, since that's what this is about. But I did want to make sure that you all understood that the Common Health program in Massachusetts provides a way for individuals who are disabled under 65 to be eligible for Medicaid, regardless of whether or not they work, and regardless of their family income. When Ticket to Work passed in late 1999, Massachusetts was able to make some changes to its current Common Health program to really support disabled adults on SSI or SSDI, and made a little bit of some ease in getting people covered. So even though we cover them under the 1115 waiver, we also have Ticket to Work authority, I believe. To be eligible in Massachusetts, we only cover people who are under 65 in Common Health. So we do have the cliff issue that was raised earlier. But there is no income or asset limit. We do have a requirement that an individual has to work 40 hours or more a month to be considered somebody who's a working person with disabilities. And we can do that because of the 1115 waiver we have. We actually look at 40 hours per month, or a combination of 240 hours in the past 6 months. It's similar to the federal rules. You have to be disabled based on the state or federal laws, and we're looking at both physical and mental health conditions. So as I said, there is no income limit for individuals who are working. However, if their income is over 133% of the federal poverty level, the members must pay a premium. And as Annette mentioned, in Massachusetts, it's the family income that you're looking at, the household income. So it would include a spouse here. And so that could create an issue where individuals have to pay higher premiums because the spousal income is included. Their monthly premium does differ based on whether or not somebody has other insurance. So as you all know, many people want to be on the program because of services that are not included in any other health insurance benefit. Primarily in Massachusetts, what we see individuals needing is the personal care attendant services. And as your income gets higher, you'll see that the premiums get very high. So one while people are eligible at any income limit, there really comes a time where there's a tipping point where it might be easier to just pay out of pocket than it is to pay the premium for the service. In Massachusetts, we have limited copays, so there are some prescription drug copays, but otherwise not for anybody, common health or otherwise. So here's the premium schedule. This is the current premium schedule. I feel like it has not been updated in quite a long time, because when I stopped being the Medicaid director in 2007, I feel like it was right around the same place. So there hasn't really been an update to that level of premiums, but you can see that if you have if you're at 150% of the federal poverty level, you start at $15 per month, and then you add $5 for every 10% of the federal poverty level till you get to 200% of the federal poverty level. So the amount you pay gets bigger as your income gets higher. The amount you pay sort of increases proportionally to your income. So you can see that when you get to 1,000% of the federal poverty level, and there are certainly people on the program who are at that 1,000%, you're starting at almost $1,000 a month, and it's $15 per 10% of the federal poverty level. And you can see that if you have other health insurance, you pay 85% of what you otherwise would have paid at that 1,000% of the federal poverty level. 60% if you're at the 150% of the federal poverty level. So for example, if you're at 150% of the federal poverty level and you would be paying $15 a month if you didn't have other insurance, you'd be paying roughly $9 a month if you do. So that's just an example of how that works. The premiums are billed on a monthly basis. If you don't pay within 60 days, you can go on a payment plan, or your coverage can be terminated. If you default on a payment plan, you are terminated. And to reactivate coverage, you either have to pay your balance, have a payment plan in place, or receive a waiver for that premium balance. In Massachusetts, we have a pretty comprehensive set of services within our traditional Medicaid program, including the PCA services. And so the common health population actually is eligible for anything, every service that Massachusetts provides under its comprehensive Mass Health Standard program, which is what traditional eligibility folks get. And the PCA services, the home health services, the DME services, all as Annette said, are things that are most important for these members. And Common Health provides them all. And we really see individuals focusing, as I said, on the PCA services. So some successes of Common Health, there's 23,000 individuals below age 65 who are within the program and working. We were an early adopter of the MIG and really were able to increase the level of participation in the program as we participated in that and with Ticket to Work. And really work closely, and I believe they still do, with other state agencies to maximize work opportunities in Massachusetts, particularly with the Mass Rehab Commission, which is the state's vocational rehab agency. And so the program itself has been quite successful. I was looking to see if there was any sort of report on how not only is the program good for individuals because it gets them to work, but also the sort of general return on investment to the state is that you're getting some tax dollars from individuals who otherwise wouldn't be working. I didn't see anything to really cite, but I know that's something we talked a lot about when I was within the Medicaid program, and I think it's certainly a benefit still today. So with that, I do have my contact information here if people think of questions after the fact, but I'm happy to answer any questions now.
So I have one, Beth. I just was totally amazed just now. This is Susie. That there are 20, I know there are more people in Massachusetts, but there are 23,000 people on the program in Massachusetts. And in the state of Indiana, we just heard there are just a little over 3,000.
Mm-hmm. Well, we've also had the program since 1988.
Well, we've had the program since early 2000s.
Yeah.
So just a little bit after that. And we had a Medicaid infrastructure grant that kind of helped to get it going. But, you know, one of the things that I wonder, you know, in your experience, what helps people to gain access to it? What are some key things that we can do in the state to make sure people are aware it's there, and then to reduce the barriers to access?
Well, I think one thing to remember, one thing that seems particularly different between the Indiana program and the Massachusetts program is that in Massachusetts, there is no asset limit. Mm-hmm. So if there's no asset limit, it's much, and not only in Indiana, you're letting people keep their retirement dollars, but in Massachusetts, as you're working, you can save anyways and go above. I heard you could keep up to 20,000 for some things that were work related, but and that there's a bunch of things that you're not counting. But in Massachusetts, the only no assets count at all. And so I think that's a big difference in people getting into the program. And so I think that is one thing. Also, as Annette just reminded me, because the Common Health program is a part of the eligibility application for anybody who participates in the Medicaid program, people can be found, can find Common Health without knowing about it, because if you come in and show that you're disabled and working, you could still be found eligible. So that certainly helps people come in. And then I think, you know, the disabled community in Massachusetts is very active and very vocal, and has been very committed to supporting finding people who are eligible for the program. And I think that's helped over the years. I'm not sure sort of over time, when I looked at the eligibility numbers, these are pretty stable numbers right now. I'm not sure exactly when the how the growth happened, but or when it happened without going back to look at numbers. So Annette might have a better memory of sort of how growth happened over time and where real outreach and what kind of outreach was most helpful to bring people in. But I know that 23,000 number is relatively stable.
That's interesting. That's interesting. And I'm not sure whether our numbers have been stable or not, and would be interested if anybody's in the chat can suggest whether 3,000 is what we typically seen in the state, or if that's a reduction. My assumption is that we have lost a few people from employment roles over the pandemic, over the last year, and whether that's had an impact or not, I don't know. So are there other questions for Beth? So Carolyn says, maybe I missed it, but I didn't see how Massachusetts decide eligibility for waivers.
So yeah, the 1115 waiver in Massachusetts is for our whole program under 65. So as I said, eligibility for this program is done through a centralized process with everybody. That Common Health application is part of the full Mass Health application, and there's no sort of special waiver process. The eligibility requirements for this are different than this. They're outside of home and community-based service. The reason why home and community-based service waivers aren't as important in Massachusetts is because we are covering comprehensively all the services that you might want to see, including the PCA services, as part of the Common Health Program and as part of our traditional Medicaid program. So there's not a special need to also be enrolled in an HCBS waiver.
So again, any other questions for Beth? And I've noticed that Annette, you've been helping out in the chat as well. So thank you.
I can't help myself, sorry.
All right, well, thank you guys very much. And again, if we get more questions, we will pass them right along your way. I really appreciate that.
Thank you.
Sure, happy to help.
No, it's been wonderful. I've learned a lot, and I know that there's some people on the call that are very interested in making improvements in how Indiana operates its Medicaid buy-in, so that more people know about it and more people have access to it. So it sounds like that those are some things that we can really work on. There's some key learnings that I got out of this that I think, just in terms of how people access and in terms of those asset limits that we really need to discuss. So we're a little bit ahead of schedule. I'm really surprised. So I wanted to just double check to see if Acacia's on the call. And she might not be on it yet. Kelsey, can you let me know? So I tell you what, guys, I think what we might want to do is just take a brief 5-minute break. So you can go grab something to drink, take a restroom break, and we'll be right back. And let's say we'll be back. I have 2:42. Let's try to be back by 2:50. So thanks. We'll be here. Hello, everyone. Are you back? So hard to tell. So we're still waiting a minute for our speaker, but I thought while we were waiting for Acacia to join us, that you could take the time to complete a survey. We have a survey that's in the chat box right now. It says Action Step Survey. And if you click on that, that'll bring up a link which will show you some of the action steps related to benefits and Medicaid buy-in and transportation, actually, that are in the current Employment First plan. So Indiana, as I just said earlier, has a larger plan that is also located on our website. And that plan was adopted in September of this year, last year, that outlines the activities, the goals for the state in order to push employment first, in order to ensure that everybody has the opportunity to work in the community at real jobs and for real wages. So that plan is several pages long, and what we've done is try to abbreviate some of the action steps that are related to our discussion today. So if you would just take a minute to complete that survey, and then we'll be talking about it more in our breakouts. So I think Acacia is getting ready to jump on. So I thought I'd just go ahead and do her introduction. She has the job that I think we all would like to see happen in the state of Indiana. So her title is Statewide Employment First Coordinator, Employment Eligibility Manager for the Oregon DD Services. Acacia joined DHS in 2013 as Diagnosis and Evaluation Coordinator for the Office of Developmental Disability Services. And in 2014, she became the ODDS Manager for Eligibility and Employment. In 2016, she started her role as the Employment First Coordinator to help coordinate employment services for people with IDD in Oregon. And her coordination works between vocational rehabilitation, Department of Education, and the Office of Developmental Disabilities. Her previous experience includes working as a services coordinator, delivering case management services, and as a program manager for a large employment provider. And before that, as direct support provider. So I feel a real kinship with Acacia. We've kind of come the same directions. And again, this is a position that we really love to see happen in the state of Indiana. We have a plan and we have a lot of activities going on, but there's not one person who's coordinating all that in the state. So without further ado, I think we have Acacia on the line and I can turn it over to her.
Good afternoon. Can you hear me?
We can. I can't see you.
That's odd. Hang on. Now can you see me? Maybe.
You sure can.
Awesome. Okay. I apologize because right when I went to log into this meeting, Zoom decided it needed to update. And so typically when I share a screen, I share it on a different computer. So I am going to try to see if I can manage to share and talk all on the same computer. Okay. All right, thank you. And thank you for that wonderful introduction. It was very kind. As Susan shared, my name is Acacia McGuire Anderson. I'm with the Office of Developmental Disability Services, and I've been the statewide Employment First Coordinator since 2016. It is a very exciting position. It was one that came about in Oregon because of a executive order passed by our governor, which I know Indiana has talked about all the different processes, and it was actually written into that order that we would have and maintain a statewide coordinator, which has been great because it's nice job security, but it is also a very fun position to have. I get to work with VR, Department of Education, and I really get to focus on helping ensure anybody in Oregon who has IDD, who wants to work in the community, can. So that's really what my position is about, and it is something I truly believe that anybody who wants to work can with the right supports. One of those supports, and what I'm going to talk about today, is benefits counseling. I understand that Indiana may be interested in including benefits counseling in your waiver, and what I mean by that is essentially having a service option for people who want to go to work to get more information about what an earned income might mean for their benefits. So we're going to talk a little bit about the history of benefits counseling in Oregon, how we added benefits counseling to our waiver, which is basically the way that we went about making sure that we could draw down federal dollars for this service. A little bit about the considerations that we had as we talked about and implemented, and then the next steps that we're taking. I'm going to talk about the plan that we coordinated as a state, but there were some stumbling blocks along the way that we still haven't fixed. Oh, I froze. Can you still hear me? Is my screen? Oh, there we go. Sorry about that. So, and now my other computer's starting. A little bit about the history of benefits counseling in Oregon. We've had a few benefits counseling programs for many years. So we have a federal program that's run by our disability rights program called Disability Rights Oregon. And we also actually have a general fund program called Work Incentives Network. We were able to request federal dollars, or sorry, state dollars, general fund dollars for benefits counseling in 2014 because we saw a huge need for it in Oregon, and we weren't able to meet that need with our federal program. So we were very fortunate that we were able to get ongoing funding, just general fund state funds for our work incentives, which is a program that has several benefits counselors across the state. They have a phone line, they answer calls, but the problem is we had a huge wait list. So people would go to work, or they would want to go to work, but be worried about what would happen to their benefits if they did. And they would go to get benefits counseling, and they'd be told, sorry, we'll be able to get to your plan in 3 months or 4 months or 6 months. But that, of course, is going to cause a big delay and can also cause anxiety and concern for people if they've already got a job. We've actually heard about people deciding to leave their job because they weren't able to get this service. So we had lots of good conversations with our partners. Vocational Rehabilitation worked closely with Work Incentives Network. We were working closely with them. And we determined that we were going to need more benefits counseling services, specifically for people with intellectual and developmental disabilities. So in 2016, we started exploring the service as a waiver service. So it wouldn't take away from the services we currently had, but would actually add a mechanism for us to get some federal dollars for people who qualified for ODDS or developmental disability services. The big thing that you have to do in order to get those federal dollars, as I'm sure most of you know, is you actually have to add it to your waiver, which could be a state plan, a K plan, a C plan, an I plan, which I always joke just because we've got quite a few different ones in Oregon, and I always want to know which letter of the alphabet we're on. But for our employment services, we actually have a very simple 1915C waiver, which essentially just means it's our plan, our agreement with Centers for Medicaid and Medicare Service for how we will deliver a service, what rate we'll pay, who will be qualified to deliver it, and then based on that, they'll match our state dollars at a certain rate. So that was what we wanted to do. We knew that that was the waiver we wanted to add it to because that's where all of our employment services were, but we knew we had a long ways to go. So the first step for Oregon and everything we do is a stakeholder meeting. We have a lot of stakeholders. I'm sure you do too. Of course, we've got self-advocates and people with IDD. They're our first main stakeholders, their family. In this case, we've got vocational rehabilitation as stakeholders, Department of Education, and of course, our provider partners who are going to actually deliver the service. So we pulled everybody together and we started talking about benefits counseling and what that would mean if we were going to add that to the waiver. So the first thing we had to figure out was our service definition. What do we mean when we say benefits counseling? What is the need and how do we go about really clearly defining when we say benefits counseling, what the person would receive? We needed to think about how long it would take. So how many hours in a year would it take to make sure that the person going to work had the information that they needed about their benefits? We had to consider who would be eligible for this service. In Oregon, we're very lucky to not have a wait list. So we actually have anybody who is eligible for DD services would be able to be eligible for this service. But in different states, that might be different depending on who's eligible for your waiver. And then, of course, the big topic is always rates. How much money can we pay for this service? How much money does this service cost? And how can we make sure that we can pay for the quality of service that we want? I'm not going to read this slide to you. I just wanted to give an example because part of figuring out what the service would look like and who could deliver the service is talking about training. Training is a big component to a benefits counseling service, and as I'm sure you all know, there's required trainings for any service delivered in the DD system. So it could be first aid, CPR, direct care supports. We have an individualized support plan or our service agreements where you train on individual needs. But benefits counseling really even goes above and beyond that. You have to be somebody who can understand the different types of benefits that you have in your state because states have different rules for their Medicaid. You have to consider any different functions that employed people with disabilities Medicaid options would have available. And you also have to understand the roles that Social Security and Social Security disability insurance, all of those different pieces that people might have as their access to service. And that can get very complicated. So we were lucky in Oregon that we had that work incentives network who had already developed a training requirement for their benefits counselors and who were ready and willing to partner with us to make that training available to anybody who would deliver this service in Oregon. So we actually already had an Oregon specific certification that we could use. And then we also talked about national certifications. But this became a really important issue for self-advocates because they really wanted to know that if they were going to get a service, that it was going to be a service that would help. And it also became a really big concern for our providers because if we're talking about this level of training, that's going to be at least 40 hours up front. And then in addition to that, there's ongoing requirements for them to continue their education, to coordinate with other benefits counselors, and make sure that they are staying up to date. So this became a big starting point on how do we make sure we can deliver this service in a way that will work for everybody. So this is where we landed, and this was after the conversation, our stakeholder group actually broke into subgroups. And so one of our subgroups was the training group, and that had a self-advocate, it had our work incentives networks, and it had our providers on. And where they landed is there would be 40 hours of training that would cover federal and non-Social Security benefits. There would be homework assignments, there would be tests, there would be field studies, there would be opportunities to pass the test, but you had to get an 80%, and then you would get a certification. After the certification, there was a job shadow, and then they could provide those services. And as you can see, it's pretty complicated training, and so we wanted to make sure that our providers were ready. So this was one of the work groups and one of the very first things we had to sort out, because when you're writing to apply for a waiver, you have to talk about who's qualified for the service. We also decided that we would accept national credentials for this. So there's one at VCU, and also one at Cornell. And so we agreed that in addition to our own state programs that we could offer, we would recognize other federal programs. This is just a diagram because, as you can tell, this got super complicated, and I'll make sure that this is available afterwards through Susan and others. So if anybody wants to look at it, I've also got this separate in a PDF. But if you're talking about training, I'd be happy to share kind of where we landed. So then the next thing we had to do, as I mentioned, is really think about what is the service that we're going to be delivering. If we're going to do a substantial amount of training for these providers, we want to make sure that they're going to understand not only the federal requirements and the state requirements, but the waiver service. So when we first started to talk about this, one of the things we heard from self-advocates and their families was, before I even go to work, I want to make sure I know a little bit about how it will impact my benefits. So a lot of times benefits counseling is about once somebody has a job, they will go through and look at their income, they'll look at any kind of bonuses, they'll look at their insurance, and they'll go through and say, okay, this income might impact your Medicaid benefits in this way, and here's what you can do to protect your benefits. Here's what you can do, like through the Employed People with Disabilities program, and they'd actually put together a report. But the issue that we were running into was some people didn't have a job yet, but they were worried, or their parent was worried, or their guardian was worried that if they went to work, they would lose their benefits. And so they really just needed a basic level of information about, in general, how much money they could earn, in general, how benefits counseling impacts their how working impacts their benefits. And so we decided that we would have two different types of service. We had lots of different names for them, and we decided level 1 and level 2 might just be the easiest way to understand it. So level 1 is our information and referral. Really, this is just to tell individuals, you can go to work, you can make, in Oregon, typically up to about $60,000 and keep enough minimum Medicaid to keep your case management services, your job coaching, the supports that you might need. And so we've got a couple fact sheets, we've got some flyers. In Oregon recently, we've increased our minimum wage quite a bit. And so we have some information on minimum wage and what that means for your benefits. So this is really just very basic information. We typically allow up to 3 hours for that service. And the outcome of that service is essentially some handouts, some kind of written documentation that you gave that basic information. And then the second service we call level 2, which is that benefits counseling report, or the work incentive summary and the benefits summary and analysis, the BSA, which you might hear about a lot. And that is the service for when somebody goes to work and has a job, And now they need to figure out, what does this mean to me? How much can I earn? What do I need to do to protect my benefits? And it actually creates a very personalized custom benefits summary for that person. And it also includes some information about what happens if you get a raise, what happens if you work more hours, so that individuals and their family and their support team can really understand, when might they need to come back and see a benefits counselor because they're working a lot of hours, or they've had a huge increase in wage, versus when do they not really have to worry about it? They're going to stay connected. They just need to report their wages. So that is how we ended up with the two different services. And I should have flipped to this slide earlier. I apologize, but this is again the level 1, that information and referral. In Oregon, we have service coordinators and personal agents, which are basically case managers, and that's who authorizes all of our services. So before an individual can get a service, they would make a request, and then it would be authorized. Then a provider agency separate from their case manager would deliver that service. Typically this level 1 is 1 meeting, and we do recommend that the entire support team, especially if there's a representative payee or guardian, that they attend. They can have up to 3 hours per plan year. It has to result in a written advisement, which is those flyers and handouts I was talking about. And then any additional hours, if they needed more for some reason, could be approved separately. And this is our level 2. And this is that more in-depth resource where they've got a report that considers all the benefits the person's receiving, not just SSI and SSDI, but also your SNAP, which in Oregon is food aid, any housing benefits you might have, you might be on Medicare, so it considers all of those. The report can't be written until all the benefits are verified. We allow up to 12 hours for this, but again, if more hours are needed, we can make an approval for additional hours for this service. So now we've got the training. We know what we're going to require of the provider agencies. We've also got the definitions. We know what the outcome of the service is going to be and what the person can expect at the end of the service. What we don't have is the funding. So in Oregon, the way that we get our general fund to go for our federal fund match is we actually have to make a legislative request for our budget. We call them policy option packages, or POPs, and we basically write up how much money we need based on estimates, what the outcome is going to be, why we need it, how we'll go forward. So we did this in 2015-17 legislative session, so right when we started this work group, and unfortunately we were not approved that year. So we did it again in 2017-19, and unfortunately we were not approved that year either. And we just did it again in the 2019-21 session, but with COVID, unfortunately, we weren't able to move that one even out to the legislature, which I think can sound a little bit disheartening, but that's what I mean by Oregon's still working on this, and I'll get to it a little bit later. I don't know exactly how Indiana funds, but I think there's usually a typical, way to factor it into your budget, and that's always the first thing you have to do if you're considering a new service. The other thing we did is we worked with our providers and we said, okay, how much money, based on the outcome, based on the training, how much money do we think that this is going to cost? And so Jean and Paula, and I just copied notes directly from our work groups into this slide, but Jean and Paula were our work incentives policy folks, and they know more about benefits counseling than I could ever know. And they basically went across the country and looked at what this paid. And we landed, somewhere in the middle, because we could see between 64 and some paid, $25. And that's really based on your state minimum wage, what you're going to expect of the service, who's delivering the service. And we landed on, in Oregon, what we think would make sense would be $54 an hour. So that would be our ideal rate to pay a benefits counselor. And that's what we asked for when we developed this policy option package, is the general fund portion of that rate, and then estimated how many people we thought would get the service. So after not getting the policy option package in that 2017 year, we came back to the group and we said, you know what? We still really need this service. Our providers in Oregon who deliver services like benefits counseling are frequently doing job development. They're frequently going to do job coaching. And so they're getting other revenue, but ultimately we anticipate that this benefits counseling is going to help them in that job development piece. And so what we said was, we can't make this a standalone service right now. We can't get the approval from our legislature, so we can't submit the waiver. However, we do have an employment path service in Oregon, which is like a pre-employment service. It typically includes classes, it can be resume writing, it can be interviews, informal interviews, really any skill somebody needs to work on before they go to work can be considered employment path. So while we couldn't implement a new rate, we did already have this service and we already had a rate. And so what we did is we just added it into our waiver and into our rule as a new service as part of our employment path service. So we rolled it out as its own component, and we defined out the service and we put it in the waiver and defined out the service, but we did it as an employment path service instead of as a standalone service. There's a link here, and again, I would be happy to share some more details. This is our actual workers guide that we rolled out. So when we implement a policy in Oregon, we've got our waiver, which is our highest level plan. It's going to usually have the least amount of detail, but that's how we get the approval for the federal funding. Then we have our Oregon administrative rules, our rules, which I just showed you a copy of. This is what they look like. This one's in the works, hence the X, but it ended up being number 7. And then we have a workers guide, which is really where we get down into the weeds and we focus on what are the expectations for the providers, what are the details of what this will look like, what are the training requirements. And so that's all here in this workers guide that I'd be happy to send around benefits counseling. We also like to roll out training tools or information for our individuals and our families. I know that often these things are pretty complicated, but really the intent here is that we could walk a services coordinator, a personal agent, a case manager through when to authorize the service, because that's always a big question for us with a new service. So it basically asks, is the person receiving ODDS services? And if it's yes, then do any of the following apply? I muted myself. I apologize. I'm just going to back up slightly, but this tool would basically just walk a services coordinator or personal agent through the process of whether or not to authorize the service. And this particular tool was also designed to help a service coordinator or personal agent decide if the person needed that level 2 benefits counseling. So this one really is focused on, do they have a job or a job offer? And if not, are they in a place where they're exceeding their limits, or they have a benefits plan, but they need more services. And so this is just to get into the nuances and help guide people through next steps. So I think I covered a lot of this as we were going, and I promise we're getting to the point of questions. It's been a lot of me talking. But the question, the big one is, why did we land where we landed? How did we set this up in the way that we did? And the first thing I can tell you when we got together with the self-advocates and families was they really felt strongly that they needed flexibility. So we wrote this service between level 1 and level 2 to be a total of 15 hours in case somebody needed more than 3 hours for the first service. Or we can even have an exception to allow more than 15 hours if somebody has a very complicated benefits plan or if they have a lot of questions. We also heard loud and clear that people wanted to have the option to go back to a benefits counselor if they got their plan, but they forgot something, or they had a question, or a new nuance came up. So let's say they were just brand new to a job and they wanted that level 2. And they didn't need level 1 because they had a job. Now they just need this full-on level 2 benefits analysis. And they have up to 15 hours, but they only needed 10 hours to develop that plan. Well, now they've still got 5 hours left that they can go and meet with that benefits counselor again and, you know, get updates, or if they get a raise, they can check in, or if they just have a question because they didn't remember a specific detail, they can go back. So that was one thing that we really wanted to make sure was available, with some flexibility. The other thing that we heard loud and clear is that people wanted to feel confident that they could go to work without losing benefits. And that's where this level 1 really came in, is the idea that you can go to work, you can make actually quite a bit of money and stay connected to benefits. If that's what you want to do, you can work quite a few hours and stay connected. But we found frequently for people, and honestly, often their families, they're really worried about those benefits and what it's going to mean. And so having that level 1 and helping them feel confident going forward was really a big piece pushed by families and advocates. Again, as I shared earlier, we also heard from job developers that this was a barrier in the process of job development. So they might find somebody an awesome job, and then the person either wouldn't take it, or they would take it and then quit soon thereafter because they couldn't access benefits counseling and they were worried. And that is not something we ever want to see. We work very hard to help people find the right job, and then to have them feel like they need to leave or not take the job because they're not sure about their benefits is really the opposite of what we wanted. So these were some of the guiding principles that we had as we were going, and what we heard loud and clear from our families and advocates and providers as we went through this. So I think that is my full presentation for today. I'm happy to answer as many questions as we have time for, Susan. So just let me know.
We have time for a few questions, actually, and I kind of wanted to kick off, and I know there's some in the chat already, but please, people, add to that. So one of my questions just relates to the status of employment for people with IDD in the state, and if you're aware where you are, because I just in terms of percentage of people who have jobs, because one of the things that we talked about for Oregon is that you're under a consent decree. Is that correct still?
A settlement agreement. But yes, essentially the same thing.
And so, so what percentage of, where are you in your goal to get people into community employment in the state?
Yeah, so we actually have a couple of different ways that we measure our outcomes in Oregon, and I'm happy to also share those. But we do have a settlement agreement, Lane v. Brown, and that agreement actually focuses heavily on individuals in sheltered workshops. We've recently closed all of our sheltered workshops in Oregon, but we have a set class from that settlement. So anybody who had been in a sheltered workshop from 2012 forward. And then we also have goals for transition age. But then in addition to that, we're of course wanting to track overall how many people we have in competitive integrated employment. And I am going to pull up really quickly my most recent report. We're actually right in the process of reporting. And this is a bit of a challenge, frankly, and as you all know, we're all experiencing because of COVID. We did have a lot of people step away from their jobs or have a furlough. We were pretty fortunate, and I don't know if you all have heard this, but I've heard this from other states. We had a lot of people get furloughed, but they were still prioritized as employees. They were not permanently laid off. And when businesses reopened, or when people felt safe to go back to work, they actually were returning to the workforce the same way anybody else was, which was very exciting. So right now in Oregon, we started in 2015, so that was our baseline. And the metric we were looking at is the percentage of individuals with IDD who are receiving employment services and working. And we started at 11.8%, which isn't super high. And as of last fiscal year, we were at 31%. So we've more than doubled the percentage and number of people that are working. And just for numbers for folks, we had 577 in 15 and over about 1,600 in 2020.
Great. That's great. Our numbers around 20%, but we have a whole lot more people, I think, numbers wise. So, well, I'll just start with the questions that I have. I'm going to Deanne's question. It's just a comment. Indiana has benefits counseling, but it doesn't set people up with long-term financial planning goals. Is that incorporated into what the benefits counselors do for people on the DD waiver?
No, but that's an awesome question. And as you're considering going forward, I am hearing that more and more from other states. I think that there are a couple of states, Massachusetts comes to mind for me, where they've actually implemented financial planning. And it's something we've considered as we go forward, because as you could tell, I'm going to be ready to make another policy option package request in the next legislative session. And that is something we've considered incorporating. So if you're starting with a stakeholder group and looking at this service, I would highly encourage considering those longer term financial planning as well.
Oh, that's great. And Carla asks, who monitors the benefit counseling services and how's the quality assured?
So in Oregon, typically our case managers monitor all of our services. However, benefits counseling, as part of the certificate, they actually have to turn in a certain percentage of their benefits analysis that they do to the Work Incentives Network folks who take a look. And they also have peer check-ins, and part of the requirement of the certification is that they review their peers' plans and then their peers review theirs, so that they've got that ongoing back and forth. So I would say it's one of the places we've got a pretty good quality metric on the services rendered. I think with the federal certifications too, the VCU and Cornell, Virginia Commonwealth and Cornell, they also have those kinds of monitoring requirements. So that helps a lot.
Okay, and that's who is required to be used for the training and
in Oregon. That's who we decided. And there's others available, other trainings available. And so I think it just really depends on your state, what you want to do.
I'm getting through some of the questions. So Tina says, you mentioned it, but it may not be clear to Indiana folks. Disability Rights Oregon is a WIPA project through Social Security. You have benefits network. Does VR pay a rate for those services? Here in Indiana, the BIN, Benefits Information Network referrals, the VR funded side has been way down.
Yes, so thank you for WIPA that is the program that does our WIPA. Vocational rehabilitation does pay some of it. Our Work Incentives Network, like I mentioned, is actually a fully state funded program, but because of the close tie to vocational rehabilitation in the past, they're actually housed under our vocational rehabilitation program. So they're part of VR. Technically, we just pay them like a grant every year. We pay wages because they're state employees or contractors instead of paying a rate. And then with our waiver, we do pay a rate. Our numbers for 2021 or 2020 because of COVID for benefits counseling did go down, but we've actually recently seen a big jump, which is exciting. The other issue we run into, sorry, this is more than you asked for, but the other issue we run into is our capacity. because of the amount of training required, we don't always have providers that have staff ready for that. They might send a staff, that staff might leave, and that can drive your numbers down just because people might want it, but you can't actually deliver it. So we're trying to rebuild that with some of our federal rebuilding funding coming from the federal government in response to COVID.
Oh, okay. So you're going to be using the American Rescue Plan dollars for, that's wonderful. That's a great idea.
It's a nice opportunity.
Yes, yes. Well, I'm glad you mentioned that because we're looking for opportunities all the time here. And that's not one at least I had thought of. I have another question from Anne. Do you know if benefit counseling is offered to people with disabilities other than IDD?
Yeah, that's a great question. On our waiver, the supports I was talking about, you have to be eligible. So you have to have an intellectual or developmental disability. But through vocational rehabilitation and through WIPA, it's anybody who has benefits and needs benefits counseling. So any type of disability.
Does Oregon have an advocacy training program for people with disabilities?
That's a great question. We have a advocacy group called the Oregon Coalition for Self-Advocates, and they are fabulous. They do a ton of work doing peer-to-peer networking, participating in stakeholder meetings. They also are very closely tied to our DD Council. We developed a peer-to-peer curriculum for employment in 2015-16 with the council and with that coalition. And that's actually a very formal curriculum to help self-advocates who have gotten a job talk to people who are interested in getting a job about what that process looks like and how it goes. We ran into issues because we didn't have a standalone service for that either. So it is available, but it's again an employment path type service. But we are looking right now at adding that type of service to our waiver so that we could fund it directly, which is exciting, but we're not there. So
that's great. Yeah, that would be interesting. I'm not sure we have anything like that, so it might be nice once you get that in place to share it. That would be great. We have a really good program run by the Governor's Council, Partners in Policymaking, which is a really strong training program. But having that locally based would be great.
Yeah, and I'm happy after this. Washington State, our neighbors to the north, I think we're the first to implement it on the waiver. So we're looking at their model, and I'd be happy to share with you what they've got. They've had it for many years.
Oh, that's great. Thank you. Yeah. I think I've gone through all the questions unless anyone notes any that I missed. Pat?
Not see any that you missed.
Okay, well, thank you so much, Acacia. And thank you much for jumping on early. Everybody give her a big hand. I really appreciate that. Thank you. And we'll be looking for those things from you. I'll check back with you.
Okay.
So can you see my screen now, guys?
Yes.
All right. That was wonderful. A lot of information and a lot of ideas. It would be nice if we were pursuing waiver redesign instead of restructure, but maybe we could have some discussions about how to float some of these ideas. So I really want to get you guys talking to each other. All right, so we're going to go to the breakout rooms now. And I'll just go through really quickly what we're going to do. And I apologize, I'm not going to put this in screen share just so I can show you a couple things more quickly, or in present mode, sorry. So we're going to randomly assign you to a group, and we have facilitators, but we'd like to make sure there's a note taker and a timekeeper, just so we can keep those times. And we'll stick with our existing times facilitators, just so you know, we have a lot of time to chat about the results when we come back. So the discussions in your breakouts, what we'd like you to do is spend just a couple of minutes talking about what Indiana already has planned. These are the recommendations, as I pointed out earlier, that we pulled from the Employment First Plan that relate to benefits. And we threw the one on transportation in there just so you know that's there. And so, you know, I know that it's not really addressed anywhere else in the plan, but here. And I think that's one of the most, you know, most often mentioned issues for people is transportation. And then second is benefits. So they ended up in the same vision area. So these are the goals and the strategies that are in that plan. And they, if you did that survey, should look pretty familiar. They were the things that were in that survey. And we just like you to spend a couple of minutes looking at that and talking to each other about, you know, are you surprised that what's in there? Were you aware there was an Employment First Plan? That's one of the things that we've been trying to do, is make sure people know that it's there and know that we're kind of getting to that implementation phase, and we need to start looking at what we need to do next. And then spend the majority of your time talking about what you heard that you thought was really exciting that you think Indiana needs to pursue. And your note taker is going to write those things down and share them with us. And we're going to compile all those together. We'd really like for you to kind of look at what are your, you know, what are the top 3 things for Indiana. But we'd like to get as many of your ideas as possible. So the note taker will be sending those to KK Daniel at iu.edu. And I want to make sure we try to get those together, because we'll be sharing that on our website as we compile all of them. And then lastly, what we want you to do is make sure that you've completed that survey and talk about what you think the top 3 things are for Indiana to do. So I know we've had time during the session to fill that out, so probably don't need to spend too much time on that, but we want to make sure we capture everybody's response. So with that, Kelsey, you can open the breakout rooms. Is everybody back? How are we doing? Yay.
I don't mute my mic. Yes, we're back.
Thanks, everybody. You want to see the results of the poll?
I had to let you know there's an access issue. There's people with low vision cannot see the links in the chat room.
Oh, they can't. Oh, I'm sorry.
No, I just found that out. So there might be a few folks that will ask you to send them the link so they can participate.
That's great. We were going to put all of this on the website, so we'll put that link on there too, because we want to continue to get more information. Thanks, Bonnie.
Yeah. Well, I've had a few hiccups with trying to click on that myself, so I thought, oh yeah, that's a good point.
Yeah. Well, welcome back, everybody. I hope your groups were very thoughtful and came up with a lot of great ideas. And I know the note taker is going to be sending that to KK Daniel at Indiana at iu.edu. Sorry, do that again. KK Daniel at iu.edu. So Pat and I will be compiling those responses from all 3 days, and we'll be sharing those with all the participants. We'll also be posting that on our website. But I thought you'd like to see today we had 32 responses, and We had a good representation of individuals with disabilities. We had a good representation of state agency personnel and service providers. And then we also had legislators, benefit projects, and, oh, 2 bins. Cool. And so these are the things that came up the highest. And I'm sure that's not going to be a huge surprise to you. Providing funding to expand reliable, accessible, and affordable public and private transportation is number 1. That is an issue that lots and lots of communities are talking about and trying to come up with innovative responses. I will tell you that the group down in the southern part of the state is holding a transportation roundtable in the next month, and bringing together all the transportation providers in that area to talk about, how do we make this happen? How do we provide some alternative transportation options? How do we ensure people are able to get to work? And the fun part about that is they're also including those entities that are businesses that are providing transportation. So hoping some great ideas come out about that discussion. And then your number 2 choice was to provide ongoing training for case managers on work incentives and include work incentives in service planning across systems. I think it's important to note that in this recommendation, I believe the intent was case management was a broad term, not just independent case managers under the waiver, but also case managers within mental health systems and other people that serve that role for people with disabilities. And then the next highest was develop and implement a community education program about the positive contributions and the rights of individuals with disabilities. How great. Thank you guys for all of that discussion and those ideas. As I said, we'll be posting all of the recordings if you weren't able to be at all 3 days, and all of the handouts on our website. And we'll be looking at the results of the discussions to make some recommendations for how do we improve that Employment First plan, and how do we, as Work to Include, focus our energy in the coming year. You all know, right, that we have an amazing opportunity right now that with the changes from the pandemic, with this last year, we have seen an amazing change and an amazing set of challenges for people with disabilities and all workers. But we've also learned that those are opportunities. Remote working is now more accessible and more, more available and thought of by employers than it was before. And remote working as an accommodation is not going to be something scary to employers. It's going to be something that they've been working with. So that's a huge opportunity. And we know as Indiana comes back to work, that talent with disabilities is going to be really sought out. I can tell you that in all the communities that we're working with, and I'm sure everybody on the call from those communities can nod, that employers really are looking for employees and looking at talent with disabilities as something that's going to fill some of the issues that they have with a smaller workforce. So this is a quote from the Harkin Institute, and I just wanted to make sure we really think about this as a time where we can change the system, that we should change the system. The challenges and opportunities before us today are clear. We must immediately build back the jobs that were lost or put at risk during COVID-19. And as we look to the future, we must permanently fix the system so that disability inclusion moves from an aspirational goal to one that's accepted and valued component of business strategy. So again, I wanted to say thanks to everybody that has participated over the last several days. Thanks for hanging in there. Our sponsors, Governor's Council, NAPC, our partner, IUPUI, our host, and IU Conference Center for all of their help behind the scenes. All of you facilitators for the breakouts, it was great to have your help. And I know that it made things work much more smoothly to have someone working through those steps. So thank you so much for your volunteering. Our conference planners, as I said, our participants. All the handouts, recordings, and polls will be on worktoinclude.org. And I wanted to mostly thank Christine Dahlberg and her Employment First leadership. And I asked her if she would kind of give us a little testimonial, as it were. And
Little send off.
A little send off.
Thanks, guys. I really appreciate all of you. It's been a fascinating 3 days. Every presentation was wonderful. The number of people with disabilities that have been part of the discussion and part of the presentation has been exemplary. I mean, this was just a wonderful virtual conference that I think really not only gave us great information from other states and what other states are doing, as well as some of the good and things that Indiana could do better. So all in all, this, I think, was well worth my time and investment to attend and be part of. And I hope you all feel the same way about your time. Employment First is something that's so important for people with disabilities and so important for Indiana as a whole and the service delivery system. This is an idea that is very bipartisan. People can get behind. I think the time is now, and we need to push for all we are worth in the next couple years to actually make as much progress as possible to make it truly increase the number of people with disabilities that are employed in Indiana, especially people with more significant disabilities. So
You're here. Thanks tons.
Thanks so much, everyone.
you guys have a great rest of your day and tomorrow.
Yes, and have a great Memorial weekend.
Oh yeah, great. Thanks.
Thank you.
Bye-bye.
Bye-bye, everyone. Thank you.
Thanks, Christine.